we are calling them now. So first phase and final phase are, the volume is huge. In between also we feel it is lesser than this, but for first phase it is very huge compared to the time available. So in physiology you will get 12 sections. This is one from the last section, I suppose. History taking and general physical examination. What does this talk about? This is history, means this history is related to whenever a subject comes to the clinician, to the medical professional, we must gather something from him or her to go ahead and establish something, that whatever medical issues are there and how to treat them. So we must gather something from that him or her. Who is the subject? In this context, in clinical physiology, we must know the some terms. Who is the subject? Anybody who is coming for medical examination or medical advice. Medical, or better to call it medical advice. Whoever is feeling that I need some medical advice, I have got an ailment, I need some medical advice, he or she will be termed as subject in our this clinical setup. In this medical science, in this clinical setup, we will call them as subjects. Whoever is coming, when we'll call that individual a patient, when some definite ailment has been diagnosed. Sometimes will be there, they will face in your professional life. Sometimes will be there due to various reasons. People are faking problems. Even people are faking problems due to some reason. They don't want to avoid some particular thing. They are faking problems, or they are feeling that they are genuinely feeling some problem is there, some issue is there. But as a medical professional, we cannot find out anything substantial and mark him or her as healthy, apparently healthy. Okay, we assure him or her that nothing, no intervention is needed, no medical intervention is needed. But whenever the medical professional, as soon as it is established, okay, intervention is needed, from that point we can call that individual a patient. So roughly we interchange these terms, whatever is the subject and patient are interchanged. In books, when in discussions you will find we refer them to as patients, people to as patients, but very strictly speaking, still some medical intervention is needed on whatever is physiological, right? Like pregnancy is not a disease. So whenever someone pregnant comes from medical advice, till there is some associated ailment, itself pregnancy is not a disease. So better not to call a pregnant lady a patient. Very strictly speaking, a pregnant lady should not be called a patient. Pregnancy itself is not a disease, it is a physiological condition. It is very much a healthy condition, but pregnancy is associated with some ailments. In pregnancy, there may be increased blood pressure. In pregnancy, there may be increased blood sugar. What if there are associated medical ailments or they are arising due to pregnancy? Strictly speaking, from that point of time, if that is established, then the lady becomes a patient, but itself pregnancy is not a disease. Okay, so this is the difference between whom we will call a subject and whom we will call as patient, but this is interchangeably or not very rationally in my opinion, but interchangeably they are used. These terms are used, the patient, subject. But just remember that we should call someone a patient only after some medical issue has been established by the medical professional scientifically. Okay, now you should know another two terms, difference between sign and symptom, SIG and sign, and SYMP-TOM, symptom. Anybody has an idea? Already clinical classes are going on, or maybe I have discussed earlier also. Difference between these two terms, difference or comparison between these two terms. Please note the spellings also, don't make. Sign is easy, you have, this is a common English word, sign, but symptom, if you have not heard, SYMP-TOM. Anybody has an idea about this difference? People who are coming from a medical background, somebody in the family member is a medical person, may have some idea. This demonstration I'm sorry, I have had a very bad cold recently, still going on. Please excuse me for that. These demonstration classes will be mostly interactive, okay? Will interact. Lecture classes are usually unidirectional. The faculty speaks out, you just listen, and students listen and take notes. Sometimes you may ask questions, the students are allowed to ask questions, that's okay, but mostly they are unidirectional. But these should be interactive classes. Anybody who has an idea what is symptom, what is sign in clinic, in medicine? So sign is something, symptom is something which is the subject. Please learn from the beginning to call this subject. Don't from the beginning, if you have these things clear in your mind, you will not make mistakes. Even in your future professional life, if you become that means you teach somebody, then again you will not make mistakes. So commonly in the clinical setup, we are, again I'm just repeating it so many times, that we are calling patient. Subject, a subject is coming to you, an individual is coming to the medical professional and speaking of some, that I am feeling this and this. I have fever, okay. I am having a headache. I am having some pain in the belly. Belly is what we call medically, we call it abdomen. The part, I am having pain. I am having pain in the legs. Okay, I am having a headache, I am having a fever, I am having a pain in the throat, or my hands and feet are feeling like burning sensation. All these are some characteristics spoken by the subject. Till not medically established, maybe not medically still established, they are coming to a medical professional. These characteristics are called the symptoms. Symptom, plural is symptoms, just add an S. Symptoms. These are the symptoms, whatever the subject is complaining of or speaking of. Whatever the medical professional is eliciting by examining the subject is a sign, clinical sign. So this is the difference between sign and subject. So very two classical examples might be, if fever is the symptom, fever, corresponding to it, the medical professional cannot elicit, he or she will not elicit fever. Whatever he will elicit, just that is temperature. That may be instrumentally or just clinically examining by putting the hand on the forehead or on other parts of the body, feel the temperature, and then using a thermometer take a record of it. So the symptom is the fever, the sign is the temperature. If symptom is pain, headache, or pain elsewhere, pain whatever, now the clinician puts a hand on that particular area and tries to elicit. Are you feeling it? Say the subject says, I am having pain in the upper part of my belly. So the subject, where? The clinician has to ask where. Clinician is the medical professional. Clinician has to ask where. Then he puts his hand over that area. Are you feeling the pain? Yes. As soon as the clinician puts the hand, either the subject makes a sound which indicates that he is feeling the pain more, or tells it verbally, yes, I am feeling the pain more, or the clinician himself asks, are you feeling more pain when I put my hand over here? Yes or no, whatever is the answer, some feeling will be there. That feeling is called tenderness. So the clinician is feeling the area to be tender. So pain is the symptom, tenderness is the sign. These are two very say classical examples. So fever, corresponding sign is temperature. Symptom is fever, corresponding sign is temperature. Symptom is pain, corresponding sign is tenderness. So this is the comparison or difference between who should be called a subject, who should be called a patient, what should be called a sign, what should be called a symptom. Now some more terms will be there as we go on. History taking means, what is history taking? History taking means knowing about, the subject comes and tells something, but we have to know, ask verbally, if the subject can speak out. In case of very young children, usually the mother of the child accompanies him or her. Unfortunately, if mother is not there, she is no more, some guardian will be there. So a very young child probably cannot speak out very well, and if it is more younger, an infant or all, there is no question that the subject himself or herself will be able to communicate. So a guardian will be needed in most cases. Most preferably it should be the mother of the child. So in those cases we will know about the ailment, whatever issue is there, from the mother of the child. In adults, mostly it will be the adult himself or herself, but again, if someone has some very grave, say, psychological issue, the person accompanying him or her will be the one, or maybe one or more of them, they will be communicating to the clinician. So the first, what is to note in history taking, obvious, that is the patient particulars. Patient particulars is not about the, actually not about the medical issue itself, but obviously we have to record what patient particulars starts with. Obvious, what is the obvious thing? Patient particular, it will be the name of the individual. So name, then age, then gender, sex or gender. Name, age, sex or gender, obviously in any case, not only the medical world, any, to describe anybody, to have an identity, these are just establishing the identity of the subject. Name, age, gender. In case of an adult person, we talk of the occupation. Before that, address is important. Okay, to note the patient particulars: name, age, gender, sex, address, sex or gender, address, occupation. Okay, now the name itself, from the medical point of view, name does not matter. Whatever the ailment is, the name is just for the identity. Obviously, it does not matter. The medical issue will itself not have any relation with the name. Name is just for identity. But age, gender, these have relations to, may have relations to the medical issue as well. Because some diseases, more in the children, more common in the adults, these things will come across as we go on in medical science, learning things. So something called the pediatric asthma. Pediatrics means related to children. You have one subject which you will have to study in your MBBS course is pediatrics. So that is about children. So pediatric asthma, so childhood asthma, childhood issues. So age has an importance in the medical history. Name is just for identity. Age, gender are also for identities, but age has an importance, may have some relation to the medical issue as well. Likewise, gender may have. There are some diseases which are carried in the females, but only the males suffer from that. One very classical example is hemophilia. Okay, you have heard of the disease, at least the name. So carried in the females, but the females usually in most cases do not suffer from it, but the males suffer. So this is due to hereditary genetic dispositions. We'll learn in the theoretical classes about that. But this is, so the sex or the gender, one very classical example is carried in the females, the males suffer. So that is, so the establishing the gender is important. Okay, so name, age, sex. The name is just for the identity. Again, address. What does common sense say? Does the address may have any relation with the medical issue, or it is just for establishing from where the person is from? Can it have? How?
So we can decide whether this disease is located on that area or not.
Yes, one thing is that. So say some address. How many? Most of you, I think, live in cities or towns. Anybody from very rural areas, villages? Anybody here? Yes. So does your house have a house number? No. In rural areas still, many rural areas are there in India where the house is not designated by a house number. Now in cities and towns mostly they are designated. So do you think this house number has any relevance to the medical issue? No. Obviously no. It cannot have any relevance to the medical issue. So that is just for where the person is coming for, just for noting, just for the record. But the area, say some area in, is it a hilly area, is it an area by the seaside, is it an area where pollution in a very congested city where it is much polluted, these have relations to medical issues. So address is important, but not the exact, these house numbers, these particulars, these are for administrative purposes. You will receive some communication in rural areas, it still happens, there are no house numbers. So if the person has to receive some communication, then if that person, it depends on whether the person is recognized in the locality, maybe the neighbors tell him about here, the postman still goes around, I'll deliver a letter, whether you know this person, this is still done. This better if the house is designated, but this is still going on in our country, in remote areas. So it is not, it is still not distinguished like that. So it is done like that. So that is for the administrative records. But some person is coming to you from a slum area. So there are issues about hygiene, and hygiene relates to medical issues. Okay. In some areas they are unhygienic, living in unhygienic areas, using, that means not getting proper, even not access to proper drinking water. So that will have relations to medical issues. So address is important in that way. Where do you live? Okay, but the address particulars, those house numbers and all, name of the road, name of the street, name of the village, that is for administrative records. That is not for connection to the medical issues. But these things have connections to medical issues. Occupation can it have any connection to the medical issues? Any medical issue? Obviously, people working in different professions, there are occupational hazards. Occupational hazards is something which you will, as a separate topic or one or more topics, you will learn in your medical curriculum. There is a subject called community medicine, whose classes are starting in the first phase itself, but you have to face the university exams in the third phase. But classes are starting itself. There is one lecture session and you will have some field visits all through this first phase. You will have some field visits and one lecture session each week. There are 14 lecture sessions each week in this institution. So the hours, mandated hours for each subject. This subject means this subjects which you have to study for MBBS, in MBBS curriculum. Hours are mandated by the NMC. Okay, National Medical Commission, but the class routine for one particular institution is decided by the institution itself. Here you have those who are still new, just recent, you just maybe getting acquainted. 9 to 11 we are having 2 lecture sessions. Okay, so lecture sessions are on 6 days, 9 to 11, 9 to 10 1, 9 to 10 to 11 1. So these 6 into 2, 6 days, Monday to Saturday, 12 lecture sessions. And 2 lecture sessions in the second half of Wednesday. Okay, so total 14 lecture sessions. One of them is community medicine. So community medicine, the discussions are starting from the first phase itself. The exam you have to appear in third phase, part 1. So in community medicine, you will be studying about occupational hazards. Someone is working in, say, mines, coal mines and all. Okay, so they are prone to different respiratory ailments. So occupations often they have relations to medical issues. Somebody is working in these polluted environment, and that too in congested cities. So address is not only home address. A person is working, say, 10 hours, 12 hours a day in some congested area and then going home after in the evening. So all these things are important in establishing this medical What do we mean by the term diagnosis? Diagnosis means diagnosis. This means diagnosis is establishing the what is the medical issue, that is called diagnosis. Diagnosing means establishing the medical issue for which the person has to be treated. In the same individual, obviously there may be more than one disease can be established. So diagnosis is establishing the medical ailment or the medical issue. So to arrive at that, all these informations are important. What we are recording in history. Still now we have talked in history about patient particulars: name, age, sex, address, occupation. Okay. Now the subject will probably see again. If we are very strict in using, we should be calling it the subject particulars, because till now, as soon as the subject enters, the individual enters, we have not anything established, but still it is called patient particulars. So probably in most cases, whenever someone is coming for medical advice, something or the other will be diagnosed. So it is called patient particulars. Now after patient particulars, just for the sake of learning, patient particulars, once you note down the patient particulars, so if you are working in an institution, if you are in a clinic by your own as a clinician, then you have to note them down yourselves. But if you are working in an institution, probably the name, age, sex, address, this will be already noted down by your institute. You are working for a hospital, so the hospital will already, before making, you are working in the outpatients department of a hospital as a doctor, as a clinician, as a medical professional. Probably the name, age, sex, address, they already, for the records, the hospital will keep it and then send them to you. You are already having it there, but you will ask whether these details, maybe the address is noted, but whether it is say a slum area or not, whether it is a congested city, where you are coming from, where the individual is coming from, those you have to take. But once you have noted down the patient particulars, there will be something called, for the sake of our learning, something is designated as chief complaints. Chief complaints. There may be one or more. If you find only one complaint, say the subject is speaking, I have fever from so many days, for so many days, and he or she is not speaking out anything more. So then only fever is the chief complaint. Chief complaints are those which are primarily, as soon as the subject comes and starts speaking to you, or in case of very young children or still younger infants, whatever the mother of the child is complaining of, if it is usually more than one, but if it is just one, it may be one. So I have written the S in the bracket. Wherever you find the S in the bracket, that means it may be one or more. So usually it is more, but even if it is one, you have to note down that what is the chief complaint. That is, chief means whatever the primarily he is speaking of. You may find many complaints, you may elicit more than one thing, but chief complaint is that complaint, or that maybe more than one. Usually they are more than one. Those are, I am having fever and headache for 3 days, along with I have vomited once, or I have nausea. This term means, you will come across these terms as we go on learning in medical science. Nausea means the feel that there may be vomiting. That is nausea. That is a nausea, vomiting. I have fever and headache for 3 days and I have vomited once last night. Okay, I am having some pain in my belly also. So these will be some complaints. So just try to interact with the subject and just try to note. Some subjects will be there who will be telling 10 or 15 things altogether. But from your experience, your knowledge, you have to gather what should be the chief one in this case. So you note this as chief complaint. Okay. Sometimes the subject will themselves help you out. Sometimes some subjects are so anxious, they are having so many issues for so many days, and they try to speak out everything at one go. So you just note that these should be the chief complaint. So note 1 or 2 of them, maximum 3 like this. These are the chief complaints. And the next heading which you passed on to, that is history of present illness. That comes actually along with the chief complaints. This is description, just getting a more detail about the chief complaints and noting the associated complaints. Okay, the associated, and what we are calling this fever, headache and all, whatever the subject is speaking out, these are the symptoms. We try to get a more knowledge about the symptoms and the associated complaints as well. That is called as history of present illness. So name a patient particulars, chief complaints and history of chief complaints and history of present illness are related, but you mark 1 or 2 as chief, which you find out that as we go on, as you become a professional, more and more you get experienced, you will get it in your mind. So this should be the chief one for this. A person is having a very bad cold, say coughing out or sneezing or having a very bad running nose. So obviously he or she may have some other ailment also, but for him or her, the chief complaint will be probably from the a respiratory issue, a issue of the respiratory system. Okay, so just note that down. These are the chief complaints. These are associated complaints. Associated complaints, you note that down under the history of present illness. Okay. Also, along with this, when you have established or when you are recording these things, that whatever has happened, whatever the subject has come for now, but so if we number them after 1, 2, 3, 4 should be history of past illness or past illnesses. So anything relevant to this or even irrelevant, anything relevant to the present complaints or even irrelevant, if there is there has been some major issue, you note that down. Okay. So obviously maybe every sometime or the other some individuals have headache or some fever or not to note down everything, but sometimes there are some major issues in the past, like you ask whether you were admitted, whether you were hospitalized for a long time in your past. Say you are meeting a 25-year-old subject. So in these 25 years of your life, have you been hospitalized for a long time, say for 1 month, 2 months in the past due to some illness, or you have had a surgical intervention, you have been operated on due to some reason, you have some major illnesses, some diseases you name, you just try to guide them, malaria, typhoid, like this. Just when you have become a professional, you know about these things, that which diseases can cause prolonged illness. So did you have this something like this which kept you hospitalized, or even if not hospitalized, you suffered for a long time? So you note that down in history of past illness. Sorry. And that includes some these surgical interventions and all. This we classify something called the family history. This is usually for the hereditary diseases, non-communicable diseases, like say increased blood pressure. These are present familially. Increased blood glucose levels, these are present familially, and these are usually some non-communicable. Again, you will read non-communicable diseases as a separate section. In our times we had, I don't know how the books have changed or not now, how the books are representing the topics. When now a separate section for non-communicable diseases, in the same we are speaking of community medicine, you will learn communicable diseases, non-communicable diseases. So a respiratory illness may be communicated. So droplets are passing through the air, communicating to other people, respiratory illnesses. But these types, increase in blood glucose, diabetes, increase in blood pressure, hypertension, these are they have a tendency to be linked familiarly, but they cannot be communicated from one person to other, okay, by some agent. Okay, so that is not carried by any agent, any disease causing agent. So they are non-communicable diseases, but they have a they are prone to be present in the familial lineage. So that is, you should have a history. So whether, say suppose you are seeing a patient who's or seeing a subject who is complaining that recently I have been diagnosed with increased blood glucose levels. You ask, why did you do it? Was there any medical advice? No, I was hearing from the neighbors that such and such symptoms may lead to diabetes. So by myself, I have gone and examined my blood glucose from a laboratory. Okay, so then you take whether there is a similar history of increased blood glucose in your familial lineage. Obviously, people will not tend to know about what was there 3 or 4 generations before. They will not know about it, but at least in the parents or siblings of the parents, any family, whatever you can pick up by verbally communicating, you just note that down. Okay, so that is what we refer to as family history. Now, history of past illness, family history, the other things which you have to note that may be recorded in history of past illness as well, but we record them separately. That is addiction history or history of addiction, whether the subject is a smoker or anything else, smoking, alcoholism or anything else, addiction to some one or more agents is there, that is addiction history. Okay, so these are some common things which we note down while taking history. Now we are learning about it, but this will maximum when you are verbally communicating with the subject. All these things maximum takes as you grow more and more experienced. As soon as you see one subject and start talking to him or her, note what may be happening. Maximum all this whole thing may be taking for communicating 2 or 3 minutes, not more than that. So you're asking one after another. Patient particulars may be provided to you if you are working in a hospital setting. If it is your own clinic, then you have to do it by yourself, or maybe you have some associate who is helping with you, but the rest you have to do by yourself. And when communicating, this will take 2 or 3 minutes. In 2 or 3 minutes, you just gather a whole, whether you just go on asking and get these things, okay, get these relevant details. More classifications is more points may be made that this, but these are the major ones. Okay, so history of but what is most important is whatever the subject has come for now. That is the history of the present illness that starts with the chief complaints. So you classify something as chief complaints and classify the others as associate complaints and record the history of the present illness. Okay. So this may vary somewhat. This is a very general idea on history taking. This may vary somewhat when you are meeting, say, subjects who have particularly coming or they have already been diagnosed, again coming to you for any advice regarding, say, they have already been diagnosed by a surgeon for some surgical intervention. Now the surgeon has sent to a general practitioner or to the doctor who is an MD in medicine for some other medical issues. So there may be some variations which you are to in this history taking, which you are to in within this history taking, which you are to, that comes by experience, which you are to note down. In case of gynecological patients or obstetric patient subjects, obstetrics should not be, pregnancy itself is not a disease. So obstetrics deals with pregnant mothers. They should not be called as it is. They should not be called patients. So pregnant individuals, this history taking varies. So they will be, you will how to note down a obstetric history, that you will learn in gynecology and obstetrics. But a general idea about history taking is this much. Okay, as you go on interacting with patients, that will not occur many times in your first phase. you are going to the words from the second phase very few times in the first phase. You will get a more detailed or more specific ideas about these things. But in the syllabus for the first phase, now they have kept the word or two we have to speak about history taking, and you just have a overall idea about how this is done. But this will, when you are taking a history for a child, so pediatric history taking, it will be somewhat different. Obviously, you will not ask the mother of a 1-year-old child whether your child is a smoker. So it will vary, but this is just a general idea. So what you are more concerned in the first phase itself is clinical examination. Clinical examination itself, out of that we have already done 2 topics: examination of the arterial pulse, examination of blood pressure. Clinical examination we are concerned from the first phase itself. Why? First we learn it on what we call as normal subjects. We ourselves can consider as normal subjects these first years too. So the how to perform some clinical examinations you learn in the first phase itself, and most times you will do it on your colleagues, on your friends who are studying along with you. So you learn what is normal to distinguish them with the abnormal when you go to the wards, to the actual individuals who are coming from for some medical issue. So in the first phase, I go on repeating in every batch, we are more concerned with how to do the procedure. Always the results will not be there, because most of the times there will be abnormal findings will be very less, very rare. We are learning only, we are getting acquainted with how to do the procedure for a clinical examination, how to examine an arterial pulse, how to examine the blood pressure, but the results will most cases be within the normal range, because in the when we are learning in the first phase. So just start by remembering this, that results are not very important as far as the first phase of your medical curriculum are concerned. But from the examination point of view, in clinical physiology, from the examination point of view, I tell you that you will have to face 20 marks more or less, maybe 5 less, maybe not 5 less, maybe 5 more, 25, but usually they are keeping 20 marks out of the 100 marks for the practical examination, 20 for clinical physiology. Okay, so you have to show various these procedures are important. What is most important is how you are performing it, how to examine blood pressure. So the procedure should not be wrong, findings will be within the normal range that is expected, but if the procedure is wrong, there is a discredit. So 20 out of 100, 40 is viva. So practical plus viva examination is 100. Viva is the oral part of the theoretical portion of your syllabus, so that is 40. So out of the rest 60 which you will have to perform hands-on, 20 is for clinical physiology. It may vary sometimes, but usually it is 20. So clinical examination, you start by remembering this. That means you start as a beginner, you start your having the knowledge by remembering this, that in the first phase what you have to more concentrate on the procedures. Next onwards, when you go to the actual patients, actual individuals which are coming for medical advice, expectedly you know most of the procedures, then you pass on to the results. So for now you concentrate on the procedures. General physical examination is just a general clinical examination or general physical examination. Whenever one subject comes to you, you must note these points. So from history taking, you get an idea, okay, this may be a primarily a respiratory issue. So you concentrate on the examination of the respiratory system more than the examination of the other systems. But whatever is included in the general physical examination, you have to do for all subjects. So we will study it by under some headings. But remember, general physical examination will have some characteristics which you have to note in more or less every subject. So what is the difference with systemic examination? As an experienced professional, as you go on gaining more and more experience, so whenever you are talking to the subject who is coming to you, or in case of children, the mother of the child, or whatever, in case of obstetric ladies, whatever. So you just have an idea by with this information from the history taking, that I'll have to concentrate on this, more on this system, more on this respiratory system, or the cardiovascular system, okay, or the gastrointestinal system. But general physical examination is in that way compulsory for every subject. Okay, so before that, just under what headings we learn the general physical examination, I'll tell you about the criteria to be maintained when you are examining a subject, and that will be, from the exam point of view, that will be asked in the exam, whether you know it or not, that will be asked in the exam. You have to maintain these things, some criteria, when you are examining a subject. So the first criteria is criteria of a physical examination. First one is, you do it in a well lighted area. So if it is a room, so it has to be a well lighted room. Most physical examinations are advisable in broad daylight, but that does not mean, obviously, a ailing person comes to you in the evening and you say it is not possible to examine you, come back later tomorrow. So that is, it cannot happen obviously like that. So broad daylight is advisable, but if not possible, if not there, bright light. So the room where you are examining, the area where you are examining should have sufficient light. So proper well lighted room, well aerated room, well lighted room is necessary for physical examination of an individual. Okay, the next criteria is a very obvious one, that is, you should make the subject comfortable. The subject should not feel uncomfortable being with you. So one of that is that the subject is not uncomfortable. You, medical professional as a male, if the person is a male and if the subject is a female, there should be a female attendant, and this is how it is written in books. So whenever you read the books, you will find it is written for a female subject we should have a female attendant. Okay, so maybe his or her for a female attendant, and for a female subject, her relative. Okay, maybe an associate with you, a female associate, okay, a nurse, somebody who is there by her side, so that the subject does not feel uncomfortable. This is how it is written in books. Now I'll ask you to say it like this. If actually the books are being written for ages, okay, very few female medical professionals or very few female doctors used to be there, say even 20 years ago, 30 years ago, few of them, or back 40 years ago. But nowadays, so many male doctors, so many female doctors. I'll just modify it for you, that you say it as, if the clinician and the subject is of opposite gender, then there should be somebody to make the subject comfortable. There should be somebody there who is of the same gender as that of the subject, obviously not the clinician, as that of the subject. So these are some problems you will face. So it is always good to have beforehand, there should be attendance of the same gender as that of the subject. Okay, only one male attendant was available, as is happening, shortage of manpower in government hospitals, also private hospitals also, due to shortage of manpower, these things happen. But ideally, obviously, when you have to examine, if you are a female professional and you have to examine a male subject, a male attendant has to be there. If you are a male professional, female subject, female attendant has to be there. Now, why books are writing, it is only for the female subjects. Now, the books are being written for so many years and years, and female professionals were less in number, female doctors were less in number, but nowadays it is not so. So you say it as the attendant should be of the same gender as that of the subject if the clinician is of opposite gender, right? So this is one of the ways how you, one of the points in making the subject comfortable. And obviously a subject enters, you cannot tell just lie down on the floor, I'll examine you. So there has to be a couch. A medical room, a medical examination room should have a couch. If lying down is not needed, okay, be seated on a chair. Don't like just sit on the floor, I am coming. So it cannot be. So there should be a couch, there should be a chair for you as a medical professional, there should be a chair for the subject to sit down. Better there are chairs for the persons who are accompanying them. There has to be a couch, there has to be a table where you are writing your notes. These things have to be there, and you are making the subject comfortable. And whatever I talked about the gender of the subject, it should be a well lighted room. That is the first point. You have to, mostly in most cases, this is generally we follow, that we stand or sit, whatever, we examine the subject from the right hand side of the subject. And we are mostly, most people are right handed. So most doctors are also right handed. If you are left handed, sometimes modifications may be allowed. But even if left handed, some things, some examinations can be, clinical examinations can be done from the right side. Mostly we do it from the right side. So these are some very general criteria which should be followed, which has to be followed, when should be not, has to be followed or kept in mind while physical examination is being done. Making the subject comfortable of some obvious things, just don't grab someone by the shoulder and start examining. I don't have time, I'll complete 15 patients in 15 minutes and go away, so I don't have time. So you have to make the subject comfortable. So that is ethically and legally also not allowed. Some legal issues are coming up, that we have shortage of doctors in the country. So till now they are increasing, but still huge shortage of doctors in the country. So these things are happening, that very less time is being devoted for one patient. So these things are practical issues in the medical field. But remember that you have to make the subject comfortable, also the persons accompanying him or her, and then examine the subject. So these are criteria for any physical examination, whether it is general physical examination or systemic. So general physical examination, there are some points to note for every subject who is coming as a medical, for medical advice, and two of them you have already been acquainted with, that is examination of pulse and blood pressure. This comes under general physical examination as well as recording of pulse and blood pressure comes under the examination of the cardiovascular system, pulse and blood pressure as well as general physical examination. So 2 points are those. But as soon as a subject enters, even without touching the subject, some things can be noted. That is, so I would suggest that this should be the first point, even without touching the subject. So general build and nutrition. Okay. Obviously, if some very obese person enters your outpatients department, or even if you are examining somebody at the inpatients department, very lean and thin or very obese, okay, so these obvious findings you can make up even without touching the subject. So that is general build and nutrition, that has to be, you have to note. Okay, now you should have a measuring tape. Okay, and nutrition, sometimes these things we measure as a part of general physical examination, that just put the tape around the mid portion of the arm. So we will learn these things in get these terms while reading community medicine, that what is mid-arm circumference, what is chest circumference, what is waist circumference. So at least if not all, You measure, you find a subject to be very lean and thin or very obese, and you, if not all, you try to measure the arm circumference on both hands, on both upper limbs, that is. So medically we spoke of it. Medically, from the shoulder joint to the elbow joint is the arm, from the elbow joint to the wrist joint is the forearm, and distal to the wrist joint, the rest of the upper limb is called the hand. What we call hand in the commonly in the English language, hand is the whole of the upper limb, but medically arm, forearm and hand are the three divisions of the proximal to distal are the three divisions of the upper limb. What is proximal, what is distal? Those who are new, you should be acquainted with you. Proximal is towards the heart or towards the mid of the heart. Distal is away from the heart. And whenever we speak of some body part, these terms will be used relative to one another. That means body parts relative to one another. Obviously, the forearm is distal to the arm, but proximal to this palm, this hand. Okay, the knee joint is distal to the hip joint, but it is proximal to the ankle joint or the foot, right? The thigh is distal to the hip joint, but it is proximal to the knee joint, like this. So, relative to one another. Proximal, distal, medial, lateral. Medial is towards the midline, lateral is away from the midline. So, in the anatomical position, what most common example we give, anatomical position, which is the lateral most finger, the thumb, but in the feet, the great toe is the medial most finger, right? Lateral most finger in the thumb, the index finger is medial to the thumb but lateral to the middle finger. So, this is how internal organs are also described. These are just easy examples, but internal organs are also described like this. What organ is medial to this, lateral to this? So, get acquainted with this from the very beginning, so that whenever you are reading topics, you don't have confusions. What is medial, what is lateral, what is proximal, what is distal? So, we are discussing about build and nutrition. At least you measure the arm circumference, maybe the forearm circumference, if possible, also the chest and waist circumference. Say very obese, then you measure the waist circumference, note it down that this is a very obese person. So, general idea about the build and nutrition, and any associated obvious finding you have. You have a large scar mark over the forehead. So, at once you just note it down and ask, what is this scar mark for? Very large scar mark over the forehead. You still haven't, in physical examination, when we learn about systemic examination, we learn how to say respiratory system examination, what part of the body is to be exposed, what area, like this. The chest has to be exposed, obviously. But general physical examination, just by looking at the subject, if you get a large scar mark on the forehead or over the face, what is this for? How did this happen? Anything abnormal, what you notice? You ask about that also. So, that is noting about the general build and nutrition and associated things. So, already these two things we have already classes on, pulse and blood pressure. These are two other points which we should note during general physical examination. Pulse, blood pressure. Along with them, we are required to note the respiratory rate. Okay. Now, ideally for noting respiratory rate, again the chest has to be exposed. But during general physical examination, even without exposing, you can try to do it. Now, just remember, when you are noting the respiratory rate of a subject, if you just count the respiratory rate by looking at the subject, at the chest and abdomen of the subject, you try to note the respiratory rate, the subject shall usually become concerned and anxious, and the respiratory rate may increase. Okay. So, just during noting the respiratory rate, we have learned already how to examine the arterial pulse. Pretend as if, as a medical professional, pretend as if you are noting the pulse. You might have noted the pulse once, but again, say on the other hand, pretend as if you are noting the pulse and just look at the subject and try to note the respiratory rate. This is how to note the respiratory rate, because if you make the subject aware that you are noting his or her respiratory rate, then maybe the respiratory rate will be different. It may be altered. So that's why during noting the respiratory rate, you pretend as if you are noting the pulse, but along with you note the respiratory rate. Next is temperature. It is not that only if the subject complains of fever, then only we will note the temperature. All these things are written in books. Whatever practical physiology practical books will follow, you have written, no need to write. Most things you don't need to write. If you have to write something, I'll tell you, like you may write that down, that about this making the subject comfortable about the gender. It is written in books that for a female subject you keep a female attendant, but I'll suggest you can write that down, that even in case of male attendant, male subject, you need a male attendant if the clinician is female. So you write it down like that, that if the subject is of the opposite gender of that of the clinician, then an attendant of the same gender as that of the subject has to be there, because it is not written in books like that. But most things are written in books. All these things are written in books. What points to note in general physical examination? So pulse, blood pressure, respiratory rate, temperature. Temperature, how to note will show, but these are the points. Next, these 5: pallor, cyanosis, jaundice, clubbing, edema, right? I say these 5 together, I'll repeat it again. Pallor, cyanosis, jaundice, another name for jaundice is icterus, another term. Jaundice, clubbing, edema. These things you have to note for every subject coming to you. General physical examination, build and nutrition, pulse, blood pressure, respiratory rate, temperature. These are sometimes called the vitals, vital signs: pulse, blood pressure, respiratory rate, temperature. Okay, so as a doctor, you are a visiting doctor in a inpatient department for the medicine ward or for the surgical ward, whatever. You just write it down in the note record of the patient. That is wherever the notes are being kept, that the nursing staff is to record the pulse, blood pressure, respiratory rate and temperature 2 hourly, and whenever you come back next, you again note what was the record, 2 hourly record, or usually it is 4 hourly, but in some cases they they may be required 2 hourly. So these are called the note vitals 2 hourly or 4 hourly. So noting vitals means noting these 4 things down: pulse, blood pressure, respiratory rate, temperature. Pallor, cyanosis, jaundice, clubbing, edema, and we can conclude with neck veins and neck glands. So these things, maybe a format of writing it is somewhat different in different books, but these are the points. Now one thing which I should tell you is, general physical examination, as you go on becoming an experienced medical professional, you do it from head to toe. Not like this, build and nutrition, pulse now, blood pressure now. Obviously you have to note pulse, pressure. So you do it from head to toe. Especially for noting, we'll describe those things: pallor, cyanosis, jaundice. So say pallor, whether the skin or some areas of the body are pale or not. Okay. So wherever there are no blood vessels, they should be reddish, but whether they have become pale or not. So there are areas to examine it. So usually we do these things, all these general physical examination as experienced medical professionals, so we do it head to toe. Like jaundice, looking for jaundice. Jaundice is yellowish discoloration of the skin or mucous membrane. Okay, whether it is pale, it can be noted, cyanosis, all these three things can be noted in the tongue. Now we do it from head to toe, and this is practical also. That means from practical means you have to make the you have to make the subject comfortable also. So this is, we do it from head to toe means whenever we examine the eye, whenever we examine the tongue, we will note for pallor, cyanosis, jaundice, everything, and also the shape of the tongue, whether the tongue is atrophied. Atrophied means very less muscle mass. We'll note it together. So doing it from head to toe means once we go to one organ or one body part, we examine it all together for different points. Otherwise, it will become uncomfortable for the subject also. I am remembering, okay, I have to note pallor. Okay, take out your, just protrude your tongue, I'll note for pallor. Now, after 30 seconds, I find, okay, I remember I have to note jaundice. Again, take out, protrude your tongue. This is uncomfortable for the subject as well. So we do it from head to toe, whatever the finding, but just for, as beginners, for learning purpose, that these points are to be noted. I should not forget. For beginners, we do it like this, that we just the points to remember during general physical examination. But as we go on becoming medical professionals, actually you are doing it for our subjects, for the patients, we do it from head to toe examination. Along, if I find that if the medical professional finds that respiratory issue is the main issue here, we'll probably spend more time firstly on general physical examination and on the respiratory system, and just grossly examine the other systems. Okay, and we do it according to convenience, and at that point of time you decide according to experience and do it conveniently, so that the subject also feels comfortable and you also require less time. Less time you devote for one single subject or patient, if you are at your own clinic, that is, if you are not working for some institution, less time you devote for one subject, one patient, more patients can you examine and you can earn more, right? That is the aim. That is the aim of life, to earn more and more and more. Is it so? No or yes? Very honestly, yes. You have to run your family, run yourself and your family. So less time you devote for your patient, you earn more, and I am saying this on record. See? So jokes apart, but you have to save time. Even if not that, you will not, obviously you will not waste time. Saving time means that does not mean not examining properly. You will do it properly, but you will do it intelligently, obviously, making the subject comfortable and doing it conveniently and intelligently to save time. Wherever time can be saved, you do not waste it. So you have to do it from head to toe examination. You do it according to the need of that particular patient, and that comes by experience how to do it. But as beginners, we learn it like this, so that points are not missed. So in the examination for the first phase, if the examiner asks you that what are the points to note in general physical examination, you tell it like this. But when you do, actually you have an idea, you are becoming experienced, you do it from head to toe according to the convenience, according to the setup, according to whatever you feel as per your medical knowledge intelligently at that point of time. But the idea is not to miss anything, which has to be examined. You missing vitals is like a criminal. Not examining for pulse, blood pressure, these are like criminal offenses. You cannot do like that. So as beginners, we learn like this. So you see how many points just for, and this varies in certain books. They are written, the format of writing varies, but these are grossly the things which you have to note. How many points I have written? 1, 4, 5, 5, 10, 1, 11, right? So I say it like this, those who are interested in, many of you may not be interested in football. 11-man team. So there are formations in football 4-5-1 like this, 4-3-3, 4-4-2, 4-5-1. So one is the goalkeeper and rest 10 is 4-5-1. So I tell it as 4-5-1. Remember pulse, blood pressure, respiratory rate, temperature, these 4 together, pallor, cyanosis, jaundice, climb, edema, these 5 together. First one is build and nutrition, and then these 4 which are also called the vital signs, these 5 and this one last point, neck veins and neck glands. So today it is already 12:35, still we will go to that room and I will just show you this, we can show it here also, but better to do it by the bedside clinically. I will just show you how to do things grossly. Friday, and everybody has to practice. I will suggest you from the first day, initial days itself, whatever is possible without instruments, you have to do it. Medical education is, it was called by the medical council once, it is strictly residential. Being the stethoscope and the sphygmomanometer, you have already learned. Those who did not attend, you have to learn, but already classes were there on pulse, on blood pressure. Today time is also short. So one thing is what I spoke about is built and nutrition, which is which I've already spoken about. There is nothing to show much, that you note, just note the findings. We require a measuring tape. I just don't have it over right now. With a measuring tape, we may measure the mid-arm circumference, forearm circumference, chest circumference and waist circumference. This is very simple, just put it around and measure. So there is nothing much to show in it, demonstrate in it. Pulse, blood pressure, respiratory rate, as I told you. So just volunteer, just come here. Respiratory rate, again it is easy, but just what to note, that you just pretend as if you are watching the pulse and just note the respiratory rate. If you just look on like this, I am watching the respiratory rate, then the subject may get answers and the respiratory rate may alter. Okay, temperature is doing it like this, just keeping the back of your hand on your forehead, on these areas of the body, just besides the neck and all, we can note the temperature, whether it is raised to a greater degree. But you have to, if you have to get a very that means very particular the figure about it, you have to use the clinical thermometer. Now usually in the first year of your medical school, you don't need to use the clinical thermometer, and in the wards also you have to do it yourself as doctors, or the nursing associates will do it for you, that measure the temperature with the clinical thermometer in the axilla or under the tongue, or most to measure the core body temperature from externally for practical purposes. The rectal temperature may be taken, but usually it should be taken for core body temperature, but usually we do it in the axilla or in the under. Why are you laughing? What is there to laugh? Why are you laughing? So we do it in the axilla or on the under surface of the tongue, and in the axilla it is usually 1 degree or somewhat 1 degree, 2 degree less than the core body temperature, but we adjust it like that, okay, by using the clinical thermometer. So temperature you have to do it clinically without the thermometer. Just simply keep the back of your hand on the, usually in the forehead, on besides the neck, and try to get an idea whether the body temperature is too raised. Usually it is about the rising of the body temperature, not falling, but you get an idea about. So pulse, blood pressure, respiratory rate, temperature. Now pallor, the general sites, the major or the common sites, so not the term should not be general or major. The common sites to watch for pallor at the, yes, so you can see over the face, over the palm, okay, on the nail beds. So you have to note for these things. And the eyes, what part of the eyes? It is lower palpebral conjunctiva. Okay, now I am having to show it from this side. So what we learned in the criteria, usually in most cases we should be on the right hand side of the subject, or if for convenience for the right hand side, so to see pallor like this. So we have to hold with our fingers, we have to just manipulate so that we can see the lower palpebral conjunctiva by taking proper consent. So how to take proper consent? This is one of the criteria of physical examination, taking proper consent. That can I examine you, and just verbally communicate and make the subject comfortable. Taking consent is not much of a thing if you just know how to verbally communicate. Now for showing you all, I am doing it from the left hand side, but usually we should be on the right hand side. If I go to the right hand side now, the vision of these people will be blocked. So I am showing it from the left hand side, but you do it from the right hand side. So how to take consent? I'll perform this. No need to tell your medical, your subject is probably, in most cases they will be laymen. There is no need to tell them like, now I'll examine for pallor, now I'll examine for jaundice. You just tell, I'll examine you, this will not hurt you. Please, do I have your consent? If you feel uncomfortable, then please communicate, then please tell me. But just allow me to examine. The subject, mostly the subject will tell, the subject will not say, I'll not allow you to examine, then what has he or she come for? But just make it sure that he or she does not feel uncomfortable. So just allow me to examine you. If you feel any problem, just point out that to me. So should I examine you? By starting with this, taking his or her consent, you start. Now to note pallor, we will just say look upwards. Now looking upwards, you make it easier for you to note the lower palpebral conjunctiva. Similarly for jaundice, we say look downwards. Okay, it is easier for you to note the upper bulbar conjunctiva. The lower conjunctiva is called lower palpebral conjunctiva, the upper conjunctiva is called upper bulbar conjunctiva. So to note the lower palpebral conjunctiva, you ask the subject to look up for noting the lower upper bulbar conjunctiva. Sorry, for noting the lower palpebral conjunctiva, ask the subject to look up. For noting the upper bulbar conjunctiva, you ask the subject to look down. Now, as I told you, when you examine when you become a professional, do it exactly like this, what I did just now. You look for the eyes, whatever you have to look for the eyes, you do it together. Now, for learning purpose, we are just noting the points separately, but you don't do it like this. When you remember pallor, okay, I see your eyes. Now protrude your tongue. Just protrude your tongue. So for protrude your tongue wholly, protrude like this. Wholly. So you just note whether there is paleness or not. Now you tell the subject, protrude your tongue and now reverse it. Reverse your tongue. Under surface of the tongue is noted for jaundice. Okay, you do it together. When you examine the tongue, you do everything together. Not like I remember pallor, I do see the eyes, lower palpebral conjunctiva, then I note the tongue. After some time I remember, oh, I have to see jaundice. So I again ask, go to the eyes, then to the tongue. This will make the subject uncomfortable. But just for learning purpose, we are making some headings. But when you actually do, whenever you see the eyes, you look for everything, pallor, jaundice, everything. In the tongue, we can also see cyanosis. What is cyanosis? Pallor is paleness, jaundice is yellowish discoloration. We'll read. I don't know whether this has already been discussed in the along with the GI system. Along whether jaundice has been discussed along with the GI system, classes are going on. We'll read it about it in hematology also. There is a topic in the hematology section about anemia, jaundice and all. And in the GI system, along with when you study about liver, this jaundice will be studied. So I don't know whether the definition of jaundice is yellowish discoloration of the skin or mucous membrane when serum bilirubin levels go above 2 mg/%. This is the definition of jaundice. Cyanosis is the bluish discoloration of the skin or mucous membrane when something that is called reduced hemoglobin, that will be discussed. Reduced hemoglobin goes below 5 g/%. Bilirubin levels are in milligram%. Milligram% means deciliter. Milligram per dl of blood. Because why this percentage? Milligram per 100 ml. 1 dl is 100 ml. So we write is units are same unit. Either we write it as milligram per dl or milligram per 100 ml or milligram%. This is used mg%. That means milligram per dl of blood. Hemoglobin is expressed in gram per dl of blood. So cyanosis is when reduced, something called reduced hemoglobin goes below 5 g/%. So cyanosis is bluish discoloration. What do we note? In the tongue, it is at the tip of the tongue. Then at the tips of peripheral cyanosis, this is called, there is something called central cyanosis, peripheral cyanosis, we will study about it. For now, you know, cyanosis is noted at the tip of the tongue, maybe at the tips of fingers. And if it is very gross cyanosis, very gross jaundice, whole of the skin may be yellowish, whole of the skin may be bluish, but prominent sites even in say just jaundice has set in or cyanosis has set in, these sites they are fast noticed. So those sites we have to notice, even if there is, say, instead of 2 mg%, say bilirubin levels have gone up to 14-15, very unhealthy, that is in a very disease state, very advanced disease state, it had gone up to 14-15 mg%, whether probably the whole of the skin of the body, anywhere of the skin of the body will be grossly yellowish. But first noted in the upper bulbar conjunctiva and the under surface of the tongue. Okay, these are the first notice sites, that whenever jaundice is appearing, say it has become 3 mg, 4 mg%, so it is in the under surface of the tongue, upper bulbar conjunctiva. Cyanosis is tip of the tongue, tip of the nail beds. Anemia or pallor, do not confuse anemia, we will read about anemia. Just make a distinction between the terms pallor and anemia. Pallor is mostly due to anemia in most cases, but always there it is not. Okay, so face or the areas of your turn turns pale, it may be due to other causes other than anemia. So don't just confuse pallor with anemia, and don't this general physical examination, we should not call it this characteristics anemia, we should call it pallor. But jaundice and cyanosis is okay. Pallor, cyanosis, jaundice, clubbing. Okay, so clubbing is something, it is the it is by definition it is loss of onychodermal angle. If you look at your own nails, okay, just where the nail bed is joining the skin of the finger, just see the dorsal aspect of your hands where the nail bed is joining the finger. So if you just look at, it is not straight, the nail bed is not just straight going and joining the finger, there is one angle. This is called the onycho for nail, and dermis is skin. So this angle is obliterated or lost. That is the definition of clubbing. It occurs in some diseases. So how to note it in general physical examination? From the side, again I am repeating, you actually should be on the right side, I am doing it from the left side for the convenience of seeing. You just note it like this, from the side you just note, don't look it from the front, don't go to the front, you have to look at it from the side. From the front, if there is some issue, it is difficult to distinguish, where you see all the fingers together from the side. Okay, you see both hands separately. Wherever bilateral examination is possible, you have to show it bilaterally. Suppose to see pallor, obviously when you are noting pallor in the or jaundice in the tongue, human beings, we have only one tongue, so it is not possible to see bilaterally. So there is only one tongue, but when you have to see in the eyes, you have to note both eyes one after another, or wherever possible it may be simultaneously. So pallor and jaundice, both eyes simultaneously. Here you may see both hands simultaneously. For the sake of showing it for the first time, I showed it separately, but you can see simultaneously. But if you do like this, it is better to show it separately. As beginners, you practice it separately, but you can see simultaneously also. Another good way to see clubbing is just make an angle like this, ask the subject to make this diamond shape like this with the hands, and then it may be noted. But as beginners, I will suggest you look from the side. Okay, see what happens if, due to, say you merge these two fingers like this, as there is this angle is there, this gap becomes like a diamond shape. Okay, so if that shape is not found, or if the onychodermal angle is obliterated, what happens? This gap is not found. But as beginners, it will be somewhat difficult to recognize or elicit. So as beginners, I'll suggest you do it like this. You look from the sides. Okay, edema is interstitial spaces fluid accumulation. Now just take off your shoes and lie down over here. So edema can be found in different regions of the body, but as beginners while learning we talk of pedal edema. Okay, it is above. So inferior extremity classes have not started. This prominent bony prominence, I'll show you. Just lie down for now, otherwise you will be uncomfortable. This bony prominence over here on the medial aspect, in the medial aspect of the ankle, is called the medial malleolus. Medial malleolus. Just few centimeters above the medial malleolus, you have to press like this with your finger for it is advisable for the beginners for 20 seconds. Okay, don't just leave it to 5 seconds. So if there is interstitial fluid accumulation, this after pressing, so this skin goes down. Okay, so it takes much time to return to normalcy, and then there is presence of it, indicates there is presence of fluid in the interstitial spaces. And for convenience, again you have to do it on both sides. Obviously, looking for it only on one side and forgetting the other side, that is discredit. From the exam point of view, that is discredit, and you are not seeing it on both sides. There may be unilateral edema, there may be bilateral edema. So you have to do it on both sides, and I think you can do it together. Okay. So just get up. So you have felt it?
Yes.
Okay, so you can do it. So above the medial malleolus, few centimeters above the medial malleolus, press with your, this is for pedal edema. We can look for sacral edema also. Okay, but just as beginners, start with pedal edema. Pedal edema above the medial malleolus, few centimeters above the medial malleolus on both sides. Okay, just press. It is theoretically, or it is book teaching is for 20 seconds, and then look that whether it is, if there is no edema, then it will come back to normalcy within a short time. Okay, so this is looking for edema. Neck veins, neck veins and neck glands. Okay, it can be, just look for neck veins. There is something called the jugular venous pulse, which we will talk of in cardiovascular examination. Neck veins, whether there are grossly neck veins will be noticed bluish in color under the skin. So whether grossly neck veins are visible or not, and for neck veins you have to just hold it with your hands like this. Sometimes glands are palpable. Okay, that means we can feel the glands like this, noting these areas. Okay, so glands are palpable, that they have swollen glands. So these happens in some respiratory diseases, and all these glands are palpable. In common cough and cold also these things happen. Some you may have experienced in your own life that these. So you have to note for neck veins and neck glands, and in the general physical examination itself. Okay, so these are some things which are you have to do for every subject. Now, if obviously if there is you are getting an indication of some respiratory issue, you find some neck glands are palpable, you again go through or ask, you may ask some relevant questions to the subject and make a diagnosis or based on your knowledge and whatever findings you have, history and clinical examination. Okay, about neck veins, jugular venous pulse we'll again discuss in the cardiovascular system, but these are the things to note during general physical examination. As beginners, we study it by points, but remember, when as medical professionals you do everything from head to toe. Okay, today there is no more time left, but next day on Friday the same topic will be repeated, and you practice even among yourselves here under the guidance of the faculty. For stethoscope and blood sphygmomanometer will be supplied to you, but I'll suggest, this is not a compulsion, I'll suggest that these two things, if you can keep on your own, it is better for your own learning. Okay, everything it is not possible to have, like hematology instruments and all, but stethoscope and sphygmomanometers, if you have, it is better. Not that it will be not supplied by the institution, but obviously it cannot be supplied for every individual. You will make groups and learn, but if you have if you have these things on your own, it is better for you. Okay, better for you learn, because you can practice it at home also. As medical professionals, you will need these things. So this is my suggestion from the first year itself. Whenever you become a medical practitioner, these few simple things you have to keep. So I'll suggest from now on itself, if you have your own, it will be better for you. Like from the examination point of view, if during the examination simple things you try to carry, like wristwatch you should have during pulse examination. You see, mobiles are not allowed during examination, so wristwatch, uh, stethoscope, even if not the sphygmomanometer, stethoscope, a measuring tape, this simple, a torch is required, in some clinical examinations. This you have. Why I suggest this? Because in the same room, when you are appearing for the exam, in the same room maybe 5 or 6 candidates are appearing for an exam. So there is some simple clinical examination you are asked to do. So you say you require a measuring tape or you require a torch. Okay. Now due to some reason or the another, there are not 6 torches are not available at your institution. So maybe 5-6 people are appearing for the exam. There are, say, maximum of 2 torches over there, but it is a very simple examination. Now the examiner asks you to do one thing, but the torch is with another person. Now what happens is the examiner shifts to another question and you miss a simple question which is simple to answer. So I suggest simple things you carry with you during the exam. This is just a suggestion. There is no compulsion. Again, there is no compulsion, but these simple things you keep with you from the beginning of the clinical examination. You purchase a stethoscope, even if not the sphygmomanometer, stethoscope, measuring tape, a torch, these things you keep with you. These will help you. This is for your own good. So on Friday, the same topic will be repeated, but you have to do hands-on. And again, I am repeating, please practice these things with your friends wherever you live at your hostels. If you are not living in a hostel, then maybe you have to do it with your family members, but they may feel uncomfortable if they are not medical persons. So it is better to practice with your friends, but more you practice, more you will gain confidence. Otherwise, what students are doing, students are not practicing even after our repeated suggestions. During the exam, simple things are students are making mistakes. So more you practice, many things will appear simple, but hands-on training is such a thing that more you practice, more you will gain confidence. Okay, so whatever knowledge you had, read the books, you can start practicing from today itself. You make some time for that, and in the next class on Friday for your group, you will practice making this groups of 5 or 6 people and practice this. There are so many clinical these beds also. You practice this making groups. After you are allotted roll numbers, we will make the groups for you according to roll numbers. For now on, make groups randomly, okay, and practice.